Good afternoon, everybody. Come on, good afternoon. You can't be that tired already. I'm Ruth Katz, Executive Director of the Health Medicine Society program here at the Aspen Institute. Thank you all for joining us for this very special session of Public Health Grand Rounds at the Aspen Institute, Charting a Path Forward, CDC's team approach to protecting health. We're very excited about today's program and delighted that all of you could be here. Before I introduce today's speaker, let me take just a moment to tell you about the event. Many of you know Grand Rounds is a time-honored feature of medicine designed to keep clinicians up to date about scientific and medical advances and to promote excellence in research and practice. Our Grand Rounds program borrows from that tradition to advance knowledge about cutting-edge issues in public health. No one, I hope you would all agree, is better positioned to speak to all of that than CDC's new director and one of the nation's top health leaders, Dr. Mandy Cohen, our guest today. Dr. Cohen is an internal medicine physician who most recently led the Department of Health and Human Services for the state of North Carolina. There, she was lauded for her outstanding leadership during the COVID crisis, focusing on equity, data accountability, and transparent communication. She also helped to transform the North Carolina Medicaid program through the state's expansion of Medicaid coverage under the Affordable Care Act. At the federal level, Dr. Cohen has held leadership positions at the Centers for Medicare and Medicaid, some of you know it as CMS, and was deeply involved in many aspects of the implementation of the Affordable Care Act. She's also had experience in the private sector, where prior to joining CDC, Dr. Cohen served as Executive Vice President at Adelade and CEO of Adelade Care Solution, which helps independent primary care practices, health centers, and clinics deliver better care to their patients. Now, normally, I don't include a speaker's academic credentials in introducing them. There's usually just not enough time, and frankly, I think people are kind of bored by it. That was a joke, come on. But in Dr. Cohen's case, I really must note one of her most outstanding educational achievements. Dr. Cohen holds her medical degree from the Yale School of Medicine. I served as Associate Dean at the medical school during Mandy's time there as a student. Now, I know I'm dating myself, but I relate this to let you know that even way back then, we all knew that Mandy was destined to do good and important, even transformational work. And she's already lived up to that expectation in so many ways. I'm biased, I know, and not too much pressure, Mandy. But I have absolutely no doubt that Dr. Cohen will prove that to be true in her work with the Centers for Disease Control and Prevention as well. Before I turn things over to Dr. Cohen, just a couple of housekeeping items. As you can see, maybe not, but up there, we are videotaping today's program. It will be up on the Health Medicine Society website within about 24 hours. Dr. Cohen's going to speak for about 30 minutes or so, after which she's going to open up the conversation for questions and comments from all of you. We will conclude no later than 1 p.m. With that, it is with enormous personal and professional pride that I turn the Aspen stage over to Dr. Mandy Cohen. Thank you, Mandy, for taking time from your incredibly busy work and travel schedule to be with us. And thank you all again for being here. Mandy Cohen.
Well, thanks everyone. And thank you, Dean Katz. I can't not call her Dean Katz. I'm struggled to say Ruth. It's wonderful to be here at Aspen. I've had the opportunity to interact with the Aspen Institute in a lot of ways and building consensus forward to really help shape how our system can work better for everyone. And hopefully I can touch on a few of those themes today. You know, we intentionally titled what this speech would be is about charting a path forward and thinking about a team approach to protecting health. And so that's what I hope you'll hear from me today, because we are in unprecedented times, and I think we need to meet this moment. And it does mean a modernized approach to protecting health. You know, for 80 years, CDC has been the nation's leading public service organization. They've been putting science and data into action, helping people and communities stay healthy. And CDC at its core aims to prevent, detect, and respond to health threats and to protect the country's health, safety, and security. And in today's globalized world, we face so many major challenges at our doorsteps, but we also have incredible opportunities. So I hope you will see this talk as a hopeful one. But I'm about to tell you about some of the threats, right? I think we know them. On the infectious disease side, whether it's respiratory illnesses like COVID or avian influenza or longstanding viruses like polio or malaria, not to talk about the newer ones, Mpox, or things that are super concerning like Ebola or Marburg, we are seeing more and more health threats, whether they are naturally occurring, whether they are accidental, or they are intentional. There are more threats. But those threats are not just infectious disease threats to our health. We're also grappling with worse chronic diseases, heart disease, obesity, a behavioral health crisis with rising overdoses and far too many suicides. And these threats are even greater as posed by all the environmental challenges we're seeing, like punishing heat and fires, floods, and hurricanes. We've seen, unfortunately, a decline in our life expectancy here in one of the richest and most powerful countries. A 50-year-old today is not going to live as long as a 50-year-old just 10 years ago. That should be not acceptable to us. We've also seen further divisions in our country and an erosion of trust in institutions, government, media, academia, science, and more. So we're in a challenging moment, but like I said, this is a hopeful talk because there's really good news. We also have unprecedented scientific breakthroughs, powerful detection and diagnostic interventions. We have artificial intelligence advancements, things that are truly game changer in my mind. We do have more tools than ever before to carry out our mission to protect health, more vaccines, more data, more scientific advancements and innovation, and we do have more interconnectedness through social media, travel, commerce, and a greater awareness. I think we've all learned a lot about the contribution of public health over the last number of years. So we're in a different moment, but I think the question facing us all now is, what does CDC and public health need to do to meet this moment? I believe that that starts with a CDC that is trusted, highly effective, but also deeply embedded into a larger and integrated system that protects the public's health, and I'll get into that. But we are first laser focused on delivering a vision that allows us to learn the lessons of the last number of years from the pandemic, and meet this moment. And a lot of these lessons learned from my own experience in North Carolina, as you heard, leading through the COVID crisis there. First, CDC right now is trying to focus on those lessons learned related to responding to the upcoming winter virus season, so COVID, flu, and RSV. So using lessons learned specifically for what we see in front of us. So 3 lessons we're really trying to implement. First, being transparent. Second, around operational excellence. And third, about building relationships. And in being transparent, we are trying to step up the pace and accessibility of communication. We're trying to communicate not just the technical and scientific information, which is incredibly important, but information people can use. I hope you saw that in our communication about how the COVID virus has changed. There was a new variant that showed up in August, 2.86, rolls right off the tongue. One where we did some rapid assessment of that, and we were able to put out communication right away. But that communication said, look, this is what we know, this is what we don't know, and here's what we're working on to learn more, and check back with us in a few days, we will have more information. And we worked with scientists, again, in the private sector, in academia, to quickly understand that variant. And so I hope you've started to see that. We are also focusing on ways we can bring our data together in new ways to give people an understanding of what's going on, bringing together COVID, flu, and RSV data that you can now, for the first time, see in aggregate, so you know what's happening in your community. Second, we're focused on operational excellence. And I held the title of Chief Operating Officer for CMS. And in the COVID response, I was accountable for the operations, not just for the science and the recommendations, but the execution of that work as well. And we need to focus on that so that we're not doing things like just I don't want to say just, but recommending a vaccine, very important, making sure we have the right safety data and efficacy. But then we also need to think about the operations to make it simple and easy for folks to get that vaccine. So that's what we're focused on as well right now, making sure that our partners and CDC are removing cost barriers, distance barriers, knowledge barriers. We're trying to improve the effectiveness of programs like our Vaccines for Children's program, which provides free vaccines to more than half the children in the country. But also we stood up a brand new program called the Bridge Access Program to make it possible for adults to get access to free vaccines. I'm very proud of the team for that rapid work for such an immense program. And then the third way, again, just focused on those lessons learned, is about building relationships and partnerships. We know that it's a team sport, and we've been working, for example, with the American Medical Association, the American Academy of Pediatrics, and CMS when it came to the new RSV immunization. As you might know, we're making history in having the first immunizations and vaccines against RSV. And this new immunization for babies is something that not only needs to be administered by our pediatricians, but we got to talk about it with our families. And so that team I just mentioned worked together to make sure there was a billing code, not just for administration, but for the counseling as well of nirsevimab, that new immunization for our babies. And again, those are the kinds of teamwork, relationship building across the government, CMS and CDC, across the healthcare system, right, to our doctors, our pediatricians, and others who are working to be the folks who are actually putting shots in arms. It has to be a team effort. So those are the way right now in the near term we're trying to put those lessons to work. But I want to spend most of my time today talking about where we go next. How do we fully fulfill the mission of protecting health and scale up those same lessons learned, transparency, operational excellence, and relationships into fulfilling that mission successfully? And it, for me, again, I falls in three buckets. I studied at the feet of Sylvia Burwell, who would never allow us to have more than three priorities. So here are the three buckets. So the first is rapidly detecting and responding to health threats, right? Pretty basic. It's the detection and response capability, number one. Second, we need to make sure we're doing the timely, common sense, evidence-based solutions to protect and improve health. So that's two. And then the third is what I've mentioning, that building towards that broader, integrated, effective system that protects public health. The first two buckets are really focused on CDC and what I'd call, quote unquote, traditional public health, being that quarterback, that foundation of public health, but recognizing in bucket three that public health and protecting health is much broader than what is, quote unquote, traditional public health. And as I go through that, I want to keep reemphasizing that we have to keep an eye on prioritization and focus. We cannot do everything, and we shouldn't try. And so as we think about what is the strategy to move forward in lessons learned, some of that is going to be about focus and prioritization. But let me go through all three buckets. So first, the detect and responding to health threats. This is absolutely crucial for us to be able to prevent harm from coming to our shores or for spreading amongst our community. We need to make sure we have the resources to have advanced detection and diagnostic capabilities to do this. We have to get better at detecting signal to a very noisy world that is out there. One of the, I think, newer exciting examples that we are certainly putting more investment in is wastewater detection. I think this is a new way in which we can detect what's going on in our communities. We certainly use this in our COVID response. It was how we were able to identify the Omicron variant, and we were able to recognize both the variant as well as the how far it had spread before we were able to do that with clinical testing alone. So that's one way in which you're going to see us both invest more, but modernize and move beyond just using wastewater. For COVID, we're already looking at it for other respiratory illnesses, but again, an opportunity to think about a detection mechanism. But that also has to be paired with that advanced detection capability, paired with advanced diagnostics. We need to make sure we're partnering with innovators in academia and the private sector, and across government to make sure we're building new lab testing platforms that can detect multiple diseases at once. And they have to be doing it in a mobile way in the field. They have to do it here in the United States and importantly, globally as well, while maintaining high quality safety standards. And once we're able to have, again, I think new lab testing platforms, we have to have ways to transmit the data from those diagnostic platforms in a standardized, secure, electronic way so that we're able to analyze and understand trends, right? So all of those pieces have to fit together: detection, then the diagnosis, and then the transmission of that information. And we know that the folks who are at the core operating those detection, diagnostic, and data infrastructures are our teams at the state and local level, right? We have to make sure that we continue to fund and resource folks to do that important work. It's why already 80% of the funding that CDC gets goes to our domestic funding. 80% of that domestic funding goes to states, tribes, local, territorial health departments. To put that another way, funding the CDC means funding state and local public health, right? If 80% of our dollars are going out to the states, I'm trying to help our members of Congress understand that. So when they hear me say we need a strongly funded, appropriately funded CDC, it means funding their communities for their constituents to be safe and healthy. And it's because those dollars that CDC gets and then give out to our state and local partners, that is where we're building the sustainable laboratory, data, detection, workforce, communications infrastructure that allows us to respond to those health threats. One small example, right, where we need to be able to pivot, right? This summer, I think you know that we had that train derailment in East Palestine, Ohio, and it was with that CDC funding that we're able to deploy rapidly environmental health specialists and then keep them there to make sure that we are helping that community long term. We've created new kinds of funding mechanisms, again, for our state, because we both need to be flexible to what's going on in each individual state. I will say, coming as a state leader, we both need the flexibility and we need standards on both what we're expectations for what we're doing related to data. But with these new kinds of mechanisms, we've given out another $3 billion to 50 states, 22 cities, 27 counties, all to support that work. But we can't just think internally here domestically. We have to think broader. CDC, as you know, is works all over the globe, and we know that a threat anywhere is a threat everywhere. And unfortunately, we've learned that hard lesson in the pandemic. And that is why CDC has 60 offices overseas and works closely with ministries of health, doing the important work. I've been sharing an example from my recent tenure here. I've only been at CDC 3.5, almost 4 months now, but I'm really proud of the work that our team has done in the malaria space. We've worked on malaria, and frankly, the reason CDC was founded was to focus on malaria, but we've been doing malaria work globally for 40 years. And that work has really helped decrease the amount of malaria overall in the world, keep it from coming here to the United States. So we actually had a 20-year period where we had 0 cases of domestically acquired malaria in the country. And then on the second day of my tenure, we had 10 cases of domestically acquired malaria in Florida. So I was like, oh boy. But it was an opportunity for us to show how our global work and our domestic work come together, right? We had that expertise, the lab capability, the know-how, because we've been doing that work to understand malaria epidemiology, disease progression, the development of and evaluation of new interventions. We were able to take that and deploy that right here in Florida. So I've been saying to folks, did you hear about Disney World closing this summer? No, you didn't. Thanks, public health, right? Disney World was open, right? And sometimes public health, when it's working, is invisible, right? And that makes it really hard to advocate for and to fund, but we have to remember that, and we have to be telling those stories, because the state of Florida and CDC deployed resources and made sure that we were spraying for mosquitoes, we were tracking them, we were analyzing them, that every single case of malaria was diagnosed and treated successfully. We helped their lab capacity. We made sure that the clinicians, it was another opportunity again of that partnership between traditional public health and health delivery, because every emergency room right in that area in Florida needed to be thinking about malaria, and again, the diagnostic test for that. So, right, that's the importance of investing abroad, investing domestically, because CDC and that public health infrastructure is a national security asset, right? It is the investment we need to be able to make us safe and healthy here at home. But it's why we also need to keep working with Congress to make sure we're modernizing our public health data authorities and our policies to support the ability to surge resources, to sustain public health workforce so that it can be available to respond when we most need it. And importantly, CDC needs support for some of the critical core capabilities of public health: data, lab, global response, those kinds, workforce, importantly, those kinds of investments that we need to continue to work on for Congress, lift up the entire public health infrastructure and make sure all of our programs can work better. I believe it's a bipartisan issue to make sure that our country is safe and that it is protected. And just like we invest in the Department of Defense, we need to invest in this critical national security asset for our country. And I hope we can agree and invest on it going forward. All right, so that's that first bucket of the protection and response. But I want to also talk about the important work CDC does to provide timely, common sense solutions to protect and improve health. I think CDC has incredible expertise to bring data and evidence and best practices to solve some of those most pressing health threats, but it needs to be modernized the way we do it. We have to streamline, and certainly we need to prioritize. Our guidelines and guidance and recommendations need to be grounded both in scientific evidence, but also operational reality. We do need to be timely and accurate, but we also have to understand what people are going through so that we can help them take the right steps to protect themselves. And this starts with CDC focusing on the most important health questions that need to be addressed, ensuring that our research is actually done to answer those most important questions. And then once we have that, using transparent processes to create guidelines, making sure that we're listening to our partners as we're doing that. We've been establishing new processes and leadership to make this possible. For example, right now, so if you want to give us some public comment, we are gathering input on important new draft guidelines that are aiming at enhancing protection of certain sexually transmitted diseases in high-risk groups after using post-exposure use of antibiotics. Sorry, that was a mouthful. So we're trying to use doxycycline for certain high-risk groups to prevent the ongoing transmission of sexually transmitted diseases. We're taking comment on those guidelines right now. We want to make sure that that works operationally as well as scientifically for folks. We're also paving the path to update information for clinicians about concerns related to PFAS exposure. This is a chemical that is a byproduct of manufacturing. It's something I saw firsthand in North Carolina that was in our water sources in North Carolina, and clinicians need tools to understand, well, what does this mean for me and my patients? So we're working right now with the National Academies of Science, Engineering, and Medicine and other experts to do an open process to put together those guidelines. So once we have that evidence base of information, we have to make sure then our communications of that information are simple and timely. We have to cut through communication bubbles. We have to have trusted messengers and make sure that everything is working for not just our technical experts, but for the public. as I said, the CDC team is really using our response to the winter virus season to make sure that we're doing that taking those first steps on common sense solutions. I was mentioning how we are trying to put our data together for COVID, flu, and RSV, and now you can go to our website and see that. But I do want to note a limitation, and this is where it goes back to the authorities. Right now, sometimes we can only give you that coordinated view at the state level. We want to get down to your community, what's happening right here. We want to make sure that we are giving as detailed information, and that takes the right authorities, the right privacy standards to do that. We're going to talk more about data. But again, we also need to prioritize the work that we're doing in fall and winter. And so that's why we're really focused. Instead of communicating with everyone all the time, there are some very particular groups that we are communicating with more intensely. Those who are over 65 obviously are at highest risk for what's the respiratory viruses this winter. So we're focused on those who are over 65, some of our historically marginalized community. Our kids are at higher risk particularly from flu and RSV. And of course, our disability community. So we need to not just do the hard work of getting the right science and the right data, but then as we're doing the communication, have to prioritize and make sure those messages meet the communities where they are. So in addition to fall and winter, there's two other places I wanted to highlight where we're really trying to bring resources together and prioritize the work. One is around addressing the mental health crisis in the United States, including, as I mentioned, the higher rates of suicide and overdose. So for example, CDC data is powering places like Rhode Island to review their overdose data. And we just gave out another 300 million in grants for opioid to action, where they use that data and share it with not just public health, again, the team effort here, they share it with other state partners, like folks who work in behavioral health and across state government. And they're able to alert folks when they're seeing high rates of overdose in a particular part of their community. It could even be down to a few blocks where they're seeing overdoses happen. And this data can activate mobile outreach teams to hotspots, whether it's shelters or food banks, grocery store parking lots, to make sure folks understand what might be out on the street and causing more overdoses in their community. On the suicide work that we're doing, we've put together a program for 24 locations across the country where they're doing evidence-based suicide prevention. Connecticut is one where I think they're doing some great work on reducing the lethal means for suicide, right? So things like promoting the safe storage of firearms, prescriptions, and over-the-counter medications, as well as intervening at suicide hotspots. So going to those locations where unfortunately suicide happens, whether it's railroad platforms, bridges, highways, and overpasses, and make sure that there's signage, make sure folks know that there are people who want to help. And then in addition to sort of that crisis intervention at overdose points and suicide, we're also trying to get upstream in the mental health space. And I love, again, to shout out to Connecticut. I happen to be traveling there to New Haven, actually, and saw the work they were doing in mental health and wellness for youth. They're doing this very cute program, Gizmo's Possum Guide to Mental Health, right? It's for grades 3 to 5. And again, I have a fourth grade daughter. So it's an evidence-based way to teach about how to take care of your own mental health. And it's really meant to think about that resilience and getting kids off to the best start in life. And that comes to my area of focus. You know, if we're thinking about fall and winter, mental health, we're really thinking about how we support young families. We know that lifelong patterns of health start at a young age. So if we want to make inroads on that life expectancy that I mentioned that is going down, we need to start now and we need to go upstream. So in addition to programs that I mentioned on youth mental health, program like South Carolina, we're supporting with CDC funds, a program called Strengthening Families. It's an evidence-based program and has a 2-generation strategy, and kids 6 to 11 and their parents or caregivers work on parallel activities as well as together. And it's meant to improve family relationships and really get out the breaking some of the generational cycles on violence and neglect and substance abuse, right? If you want to prevent overdose, you have to prevent upstream. And I think this is a really incredible way to think about promoting resilience and the positive buffers for kids. So you're going to see more of that for us, as I said, in the mental health space and in the young family space, whether that's also, I could go on maternal health and vaccines for children, lead detection, our school health program, childhood injury prevention. Those are some of the examples where I think CDC can bring that timely evidence-based information to have common sense solution for folks, but we need the resources and the authorities to do it. Okay, so those are the two main things that I think are really focused on what I'd call traditional public health, what CDC can bring, what our local public health can bring. But we have to go beyond that. We go to this third domain, which is creating a system, a true system that protects health. As we chart that forward, we need to think about those places of connection and collaboration because we cannot do it alone from traditional public health. I think CDC as the quarterback and foundation, as well as local and state public health, are necessary, but not sufficient to protect Americans. And partnership in that with public health, government, private sector, social service, academia, both domestically and globally, have to be a core competency for CDC and public health. Partnership has to be a priority as we go forward. It's a priority for me. And I hope that it becomes a true competency, just like data is a competency, that partnership is part of that competency. I think most urgently, we need to knit together the silos that I see out there. I think silos were not our friend during the pandemic. I think we got a lot closer together when we had that shared mission and shared aim to think about responding to COVID. And I think we need to continue on that journey. And it starts with knitting together these silos through our data integration. I think data is the oxygen that powers our ability to collectively detect and respond, and we need to do more. So let me point out of like a few examples, like if our data was working great, what would that look like, right? So if you recognize that when someone's sick and feeling really, really sick, they go to the emergency room, right? They're not stepping into a public health department, they're stepping into an emergency room. So right away, we need to make sure we're getting data from our emergency room. So imagine someone coming in with a potential case of a hemorrhagic fever, right, in an emergency room. Something like that should be triggering an all-team approach to an investigation and a response, a rapid scale up in order to save lives. Here's another example. Folks who unfortunately maybe had some bad food somewhere and having some GI distress, again, walk into either an urgent care or an emergency room, and we're seeing a few of the same foodborne related illnesses that come from it, maybe a detection of a hepatitis A outbreak, right? Having that information flow from our emergency rooms or electronic case reporting to make sure that we are quickly identifying the source, offering treatment, is one way in which we can contain that and make sure not more people are not getting sick. I think for far too long, our public health system has existed separate from our health delivery system. Now, work has been underway to modernize this system, and I think we're on the right track, but we need to keep going. So even just through the pandemic, and I've shared this a lot, right? One of my first jobs in North Carolina in response to the pandemic was a program we called Kill the Facts, because we were still receiving lab data through faxes. So we had to have 200, 300 people a day going through faxes and putting that information into systems. Now that doesn't happen anymore. That's great, but we did it for COVID, right? There's lots of other diseases out there. So let me give you a sense, like I think there's been a lot of progress. Before the pandemic, less than 200 healthcare facilities were able to send what's called electronic case reports over to public health and have that data exchange. Today, 28,000 healthcare facilities can now do that. So that's great progress, but I'll tell you, there's a lot more than 28,000 healthcare facilities out there. And we can do it for COVID, but we got to do it for more. We also now have about 80% of our emergency rooms sending in an automated, low burden way, real-time data feeds that allow for early detection of those kinds of trends that I said, right? For maybe a hemorrhagic fever or a foodborne illness. So 80% are, but that means 20% aren't. And we still have some limited ways of the kinds of data that come through those pipes, but we should be getting to 100%. We have some common operating platforms that allow us for some of that situational awareness, but we have to do more, and we are. But the point I want to leave us with as we go into questions is this is not just about technology improvements. This is also a shift in culture, in attitudes. We have to importantly move away from a mindset around data that this data is mine. Just because you collect or steward the data, it does not make that data yours. And I think we've all learned that public health data is a critical national security asset and needs to be looked at that way. It has to be made widely available to help us navigate that. And I will say that mindset shift needs to start at CDC, and we are not there. Candidly, we have work to do to even share data internally, but we are working on it. And I'm really proud of the team for coming to the table and making that happen. So we have to, as we get that data to knit us together, it also means we have to make sure that we have the right roles and responsibilities that are outlined between healthcare and public health, who's doing what and when, make sure we have those right data integrations, the resources and authorities to do this work. But I think that in addition to having that data, then we also need that shared agenda, and it comes back to the prioritization that I talked about. We need some of those good key use cases that we can say, look, this is how we're all going to articulate our roles and responsibilities going forward. Here's what public health does. Here's what the health delivery system does. Here's how we pay for that going forward, and we need to prioritize. And public health, this is hard for us. I'll just say it is hard for us to prioritize because we have such a big mission, protect health, and there are so many threats, but we have to get to that difficult discussion of prioritization. And so we're going through that at CDC right now. We're in the beginning stages of understanding that. You've heard me articulate some of the priorities, but I think there's a lot more beneath that. But I think that requires that from all of us. We have to recognize that there are some activities that we'll need to pause or even halt altogether in order to make sure that we are truly being able to meet our mission of protecting health fully. All right, so I'm going to stop there and let me recap. So to meet the challenges of the future, we need to modernize our team approach. I think CDC needs to bring its A game as the backbone of protecting health in America. We need those resources to work at home and abroad to detect health. We need to prioritize research and evidence development on the key health threats and craft timely, accurate, and easy to understand solutions for people. And then we all need to build towards that integrated system of protecting health. It does start with data integration, but it also needs to have clear role clarity and an aligned and prioritized agenda. So there's a lot of work ahead. I outlined a lot here, but it's an important and critical mission, and it requires all of you. By the way, you're all on Team Protect Health. Providers, policymakers, researchers, our friends on the Hill, the media, we all need to be part of this team together. Our country deserves it. Our country needs it. And so I look forward to working with you all together on this important mission. Thank you for letting me be here, and I look forward to your questions.
Would you identify yourself, your name and your affiliation?
Dr. Goldstein.
Hi, my name is Melissa Goldstein. I'm a bioethics and law professor at George Washington University. I also refer to Ruth as Dean Katz, my former dean. My primary appointment is in the School of Public Health. I teach the people who hopefully will work with you one day.
Thank you.
This afternoon, I'm teaching a mandatory ethics class for the MHA students, the Masters of Health Administration. Now, these are the people that are going to run hospitals, run healthcare institutions, right? We do not have a mandatory course in ethics theory, ethics principles for the MPH, the Masters of Public Health, or the undergraduate public health students. And I'm wondering your opinions about education. We've all seen over the past several years, the one ethics issue that we're talking about is prioritization, particularly in the rationing, which I saw in the news yesterday. We're now talking about the need to ration RSV vaccines because there are not enough for all of the population. So I just want your ideas about education for the people that one day will work for you,
Thank you.
with you, for you.
Thank you. Well, so I think this talks about the prioritization conversation that I think is really important. CDC, I think, like I said, has incredible researchers that need to look at a wide swath of threats, importantly. But we need to also be better at communicating risks to folks. My favorite question of our team at CDC is like, is this a 10 out of 10 or is this a 3 out of 10? Like, help me understand, where are you in your level of concern? And we need to be better about how we communicate that. The way I will bring that back to sort of training. I think it is, we do not have enough training in how we communicate. Maybe I'm using different words, you're using ethics, I'm using risk-based communication in terms of how we think about both deciding what to do and also, importantly, what not to do. I've been talking with our team a lot. It's easy for me as a leader to articulate principles. The hardest thing, or like our areas of focus, the hardest thing is to say, well, what are we going to stop doing in order to make those happen? It's the same thing, and also the threat-based communication. There's a lot of things that could go wrong. I was, you know, and we want folks to know, but some things are like pretty niche. Whether I was thinking just in the past week, we communicated about safety related to people who have pet frogs. Important for people who have pet frogs, but that's probably a really small niche kind of community. So how do we reach those folks, but also save the headspace of everyone else who doesn't have a frog to think about the other things that are really important to them? So, and then when we get to some really challenging places, which is supply constraints, those are really challenging issues. I think probably some of the hardest things I want to say probably the hardest months of my life professionally was when we first had limited supply of the COVID vaccine, and really thinking about resource constraint in our environment, in our country. We're so lucky that happens pretty infrequently, but when it does, it is really challenging. And that's where we need to lean on academic partners and make sure that we are practicing scenarios where we can think that through ahead of time. So, because in the heat of the moment, these are really, really challenging issues to have to think through. So appreciate the feedback.
Hi there. My name is Glenda Young Marquez, and I'm here with my team from NACCHO, the National Association of City and County Health Officials. And I proudly worked every single day of my life from the start of the pandemic and continue to work on pandemic-related issues under a CDC grant. I work on the Health Equity and Social Justice team. And one of the biggest issues that we have at the local level is culturally and linguistically appropriate communication. We don't hear enough about how the CDC is going to tackle that. There's a deficit of diversity at the CDC in being able to, through lived experience, have this kind of impact at the community-based level. And I'd just like to hear what are some of the plans to be more culturally relevant and appropriate, and also culturally humble.
Yeah, great question. One of our areas that I think of very much a lesson learned is how we communicate. And sorry, this is okay. How we communicate, and some of that starts with not just the words we say, but also the messenger. Let me talk a bit about my experience in North Carolina and leading there, where we partnered deeply with community organizations and resource them in order to be messengers to their community. And that was hard to do. And here's why. And one of the things I think CDC needs to do better. In order to work with those, they had to contract with the state government. That is a skill that a lot of community organizations who are trusted have never partnered from a financial relationship way with government, and making sure that our contracting processes allow for those trusted parties to compete, and we should compete for where those dollars go, but making sure we have processes that are open and allow different groups to participate. So that is a structural thing that I think we need to and are working on at CDC. And then there's our expectations of state partners and local partners from the CDC to say, our expectation is that we want to see equity. Let's say we use vaccinations as a thing at the moment. We want to see equity in vaccinations. That might look different in Illinois versus Georgia, right? And so we don't want to say, well, you have to use this group and say it this way with these things, right? Because we want you to tailor to those trusted messengers, but our expectation should be equity of vaccinations. And so, and then hold folks accountable to that and ask them to say, these are, and coach folks, like, these are ways in which you can get to equity of vaccinations. I'm really proud in North Carolina, that's what we were able to do, right? We were able to vaccinate our African-American and Hispanic communities at frankly higher rates in certain age groups than our white communities. And we only did that, I believe, with working with trusted community partners. But I also appreciated the CDC not telling us in North Carolina how to do it, because they didn't know us that well in North Carolina. They shouldn't, that's not their role, right? But we were able to do it, but they held us to an expectation. I want equity in those, right? So I think contracting as well as accountability for what we want the outcome to be, and technical assistance to help folks get to that goal.
Thanks. My name's Kevin Killeen. I lived in Hawaii when they had the fuel leaking into the aquifer. So it was a 10 million gallon fuel depot at Red Hill. It's been leaking for decades. So nobody knows where the fuel goes, and people are still nervous about that. So the Department of Defense wasn't really transparent about it. So you mentioned North Carolina, the PFAS. What about the diesel in Hawaii? And also I want to ask a COVID question. The FEI said that there was a lab origin back in July. They came out with, the DOD came out with a report that said the COVID came from a lab. But is CDC going to come out with a report on that? Because there are all these different agencies, and some of the stuff came out in the subcommittee on coronavirus, so that only had partial information. So do you have anything to add to the FBI report?
Yeah, so let me do the Hawaii issue. So I'm not aware of that, but thank you for putting that on our radar. We obviously have a large team that thinks about environmental impacts, and so I'll learn more in that space. And in terms of, you know, where do threats come from? I think of course, I am very focused on recognizing that the next threat could come from a lab, it could come from nature, it come from an accident. We have to be ready for all of those. I don't think the CDC is engaged in the looking back and where, but making sure we're looking forward to make sure no matter where the next threat could come from, that we are prepared.
Hi, John Auerbach at CF, formerly at CDC and at the local and state level. First of all, thank you for the work that you're doing. The last few years have been really tough on the public health system in terms of the amount of trust that people have had with public health. And I guess I wonder, how do we change that? And particularly when there's so much misinformation that's constantly being released to the public. Are there thoughts that you have about building trust and also dealing with the tidal wave of misinformation which occurs every day?
Yes. So, I take a lot of lessons in trust, again, going back to the work we did in North Carolina. And I give credit to Governor Cooper, who I work for, who said at the onset of the pandemic that our success in our response in North Carolina was going to be won or lost on being able to maintain trust with the public. And we said it out loud, and we focused on it, and we measured it. And the good news is that we actually saw trust go up in public health in North Carolina. And so there are lessons learned there, and you heard them embedded in some of what I said. I think it was really important we were transparent with folks, which means sometimes it was me answering questions saying, I don't know the answer yet, but we're working hard to find it out. I think it was also really important, again, that we focused on the practical realities of operations, not just making a recommendation, but also making sure that that would work in reality. And the guidance we were giving was going to match what folks were experiencing, and hearing from different perspectives, like schools who are like, we can't, those guidelines will just not work for us here. We want to be safe and protect both teachers and students. Help us. And that was really important feedback we needed to hear. And then importantly, it is about relationships ultimately. And I think showing up over and over is part of that relationship. So I am racking up the frequent flyer miles, showing up all over the country. I've been, as you heard, I was in New Haven, but like right at Miami, San Francisco, Denver, right? I'm trying to show up in person and listen, number one. And I'm trying to do that also here on the Hill. I'm here in Washington a lot because I want to hear where folks are and concerns, so that I can incorporate that into our thinking of how we move forward. And on the misinformation front, the way that I think about it is two ways. One, I think you have to flood the zone with good information. And unfortunately, you can't just put up information on a website and be like, we're done here, right? We need to cut through the noise. We have to be as engaging on the public health side as the misinformation is engaging. And we aren't. We need to think about the way we are communicating in, frankly, a much more fun way. Why can't we have a little fun with protecting ourselves, right? So I am trying to think about ways we can do that. And we're government, so we're not going to always be the most fun. So this is where partnerships are important. There are much more fun people out there that we can partner with. So that's one, but it's also about being personal and real. So I try to also share with folks a lot about me personally, and the fact that I have two kids who are, two girls, 9 and 11. And I talk about, what my kids got a updated COVID vaccine last week. And here's why, as a mom, not just a CDC director, I chose that, right? Just trying to make it a little more real for folks. So we're trying to attack it from a few different ways, but this is I need your help plea, right? I think this is on all of us to think about how do we do that work together.
Hi, Ann Mosley. I want to say thank you, Dean Katz. I'm a colleague of Bruce here at the Institute. I attended the Aspen Institute and do a lot of work on family prosperity and well-being in a 2-generation approach. And I'm sort of building on John's question, where I'm really, I love how you named partnership as a competency, just like data. And one of the parts, if we're trying to put family well-being like at the center, we're exploring both with we have about 140 fellows and almost 600 partner organizations, same North Star, but come out from workforce to health and human services, early childhood. And if we can have a shared methodology where the 2-gen approach helps. But I'm wondering where I loved your North Carolina model, and Susan Gale Perry just said to say hello. From North Carolina. What ways can we maybe think about new public-private community partnerships where states might be able to cross agencies between federal and state, do a new community infrastructure intermediary that's stronger on trust, that could get to the messenger, but if it's home visiting, or a different sort of workforce area that makes it easier for financial capital to connect with the social and human capital. And it's something that I'm from an efficiency standpoint, but also effectiveness and also the equity. Curious what kind of models or ways you could see to partner with the public sector.
Yeah. That's a big question and probably a separate talk, but about some of the work we tried to do. And actually, I think some lessons learned where I would probably do it a little differently, knowing what I know now and how we did some of our work in North Carolina. So again, without going into it for all the other folks who haven't seen what North Carolina did in terms of our investment around health and using some of our Medicaid dollars and to help for infrastructure. And we also created a data infrastructure for that. So, but what I would say is that we want to make sure that you are leveraging existing structures. So I think that we tried in North Carolina to potentially build some new things, which which felt right at the time, but they were probably existing structures that we could have leveraged that weren't quite as community oriented as I would like, but they had some structural resources that could have allowed us to move faster, and we should have figured out a way to pair them. Anyway, this is more detailed, sorry, everyone else, but we should talk offline about it, because what I don't want is duplication. Like, yes, if we blew it all up and did it differently, could it be better? Absolutely, but that's not the reality of what scales. And so it's really important to think about scaling on day one as you think about how to improve for communities. And so I'd encourage us to think about scalability from that perspective. So a whole new always makes me very nervous because it's just not possible to scale. And so what's already there? What could we leverage? It's not going to be perfect in all things. How do we give enough flexibility, but ask for particular accountability and outcomes? All right, now I'm in a whole philosophy thing, but and the partnership piece comes from the fact I was Secretary of Health and Human Services. I was not the public health director. I had Medicaid and mental health and early childhood, and you have to bring all of those together. And so we're trying to do that at the US government federal approach too. Like, how do we work together? And certainly starting with my relationships at CMS. So we're starting there. So there's more to that story, but that would be think about scalability from the beginning.
One more.
We'll do one less. Oh yeah, sorry, we're right at time.
Thank you so much, Dr. Cohen. My name is Dana Walter. I'm with General Dynamics Information Technology. We met earlier. I lead our public health strategy for our federal health division. I'm actually, my personal life, I am a suicide loss survivor, so I was greatly encouraged to hear that you are combining the mind-body connection that we know is health and forwarding that in the public health space. So I just am so thankful for that. I just want to ask you, this is a little bit of a packed question, so probably won't have time here, but in a nation where we are constantly given the mantra, it's not illegal to be mentally ill and it's not illegal to be homeless. How is the CDC partnering up with SAMHSA, VA, CMS, and all these agencies that are trying to do good work to implement true, timely solutions for folks struggling with what we know are the underlying causes of suicidality, serious and persistent mental illnesses such as bipolar, schizophrenia, schizoaffective disorder, and these kinds of issues that require a different solution than our current public health systems offer?
You know, complicated question. And this is where, when I talk about prioritizing on the public health side, making sure what is public health's role in what you just identified versus what is the payment structures versus a delivery structure, right? And making sure we have clear roles and responsibilities and accountability. Like, what do we want, right? What is it that we're trying to achieve, and what does everyone play? And where I think CDC, importantly, right, is to bring the data visibility, right? So where is the problem? What is the problem? What are the best practices and evidence that we should map to that solution? And then make sure that all of our partners that are in that space have the data, evidence, and best practices to implement. And you're going to start to see even more of this. I think CDC has actually done a lot of this already in partnership with SAMHSA. And I'm actually grateful that our leader from CDC is actually now the deputy at SAMHSA. What a great way to strengthen partnerships. So more to come on that, but that's where public health, we need to prioritize what is it that public health can offer and do, and then make partnership a core competency also of what CDC does, right? Because we need that, but I think we first need to agree on what are we trying to achieve, who's accountable, and then how do we give folks the resources and visibility to get there. So more to come, but it is a priority area. All right, thank you so much. Thank you again, Dean Katz.
Good luck to your staff, who's going to get mounds of letters from the people who have pet frogs.
Okay, so no, it's important.
I guarantee.
Protect yourself if you have frogs. Okay, thank you.
Thank you so much.